Hello there. My name is Dr. Asan Hussain. I'm an assistant professor at Dalhousie University in Halifax, Nova Scotia. And today I will be talking to you about squamous cell carcinoma of the eyelid, which is the second commonest eyelid malignancy that we see in the Western world. So this lady was referred to me with a lesion of the right upper eyelid. And you can see a lesion there which is causing some mass effect. It's fairly circumscribed. It displays some telangiectasia and possibly some change nearby there. And it actually had quite a rough surface inferiorly. And biopsy was performed, and this demonstrated a squamous cell. And she required a wide excision and a Cutler beard flap. And you can see her there with the flap. And that is a discussion for another day, how that surgery is performed. She did very well thereafter. So the first part of this talk is to establish the diagnosis. And I'll give you some historical perspective on this tumor. In 1902, the first reported case of radiation-induced or Röntgen-induced SCC was reported by Frieben soon after discovery of X-rays. And in the same year, Krompecker distinguished between basal cell carcinoma and SCC. And towards the later part of the 20th century, improved dermal pathology allowed better delineation of the prevalence of squamous cell in the eyelid, and there were more reported cases of that. So we'll come to the etiology. The pathogenesis of SCC differs at various anatomic sites based on the oncogenetic pressures at that site. So we know that SCC of the eyelid is primarily related to sun exposure, similar to the occurrence of SCC in the conjunctiva. Why is that the case? Well, it might be that UV radiation acts synergistically with cutaneous HPV, or human papillomavirus, and that might be the initial pathway for development of the cancer. The presence of precancerous lesions, of course, like actinic keratosis, which are keratinocyte derived and found in fair-skinned individuals, exposed surfaces are predilections for development of SCC. And there's likely a multi-step carcinogenic model for development of SCC. This is to do with underlying genomic instability, as we mentioned, higher UV exposure, and then tumor suppression and activation of tumor suppressor genes is also very important. How common are SCCs? Well, this does vary based on factors that include sun exposure. In a study in 2013 in Iran, a 10-year review of 100 periocular malignancies in a tertiary center showed that BCC represented 83% and SCC was 8%. In Pakistan, in Peshawar, a study was done in 2013, which showed 59% of lesions were, out of 222 eyelid malignancies, were BCC, 31% were SCC, sebaceous carcinoma was 7%, and melanoma and others were 2%. As you go further east, it appears that there's an increased incidence of sebaceous carcinoma. So in Hong Kong and Singapore, for example, they found in studies they've performed in 2011 and 2012 respectively, an incidence of, a prevalence of about 11% of sebaceous gland carcinoma and only of about 4 to 5% of SCCs. So as you can see, it varies around the world. We know that in Australia, because of the high degree of sun exposure, periocular SCC prevalence is very high. In a paper by Malhotra in 2004, they found that out of 79 periocular SCCs, the Australian Mohs database reported 79 of these SCCs were, 68% of those were in the lower eyelid, 24% in the medial canthus, and 7% in the upper eyelid, as you would expect based on the angle to the sun. And most of those tumors were primary tumors, 73%, and about a half were well differentiated. There were also found some cases with perineural invasion, although these were only 3 cases out of 79. And other studies have shown similar results from the MD Anderson Cancer Center and the study at Wills Eye Hospital in 1994. So when we take a history for this patient, it is helpful to define the relative degree to which the patient was exposed to the sun. I always ask the question, you know, have you ever had a history of significant sun exposure or particularly blistering sunburn, which is very important. So their sun exposure may be through their occupation. So for example, people who've been out to sea or in the Navy, for example, and a military history, they may have been exposed. Truck drivers, or you know, people who have a lot of outdoor work that is important, such as farming. Ask about the medical history. Is there a history for radiation on the face for any reason, such as acne, or any other history of eyelid malignancy or facial malignancy, for that matter? Any previous history of skin cancer might suggest recurrence and more extensive local progression. Then we talk about the actual lesion, how long it's been there for, how has it changed, the rate of growth, prior biopsy, inflammation, bleeding. Ask about, of course, pre-existing lesions such as actinic keratosis, Bones disease, radiation dermatoses, burn scars, and inflammatory lesions. And this is important to discuss also with the patient's dermatologist if they're under a dermatologist. Some lesions may have actually been removed or burned off without a pathologic diagnosis, and that's something to be aware of. What do these lesions typically look like? Well, they are hyperkeratotic macular, which means flat, or nodular, as in my lady, elevated, which are elevated skin lesions. They can have a significant inflammatory component. Later phases can show ulceration, and they are, of course, associated at sites of sun exposure. The eyelid architecture is damaged, such as loss of eyelashes and eyelid margin distortion. And also always, which I always do in the clinic, is feel for lymph nodes and regional lymphadenopathy. And I immediately in the office, for any suspicious lesion, perform a punch biopsy in the office chair. And you should take as big a lesion as big a biopsy as is feasible, preferably toward the outer part of the tumor so that you don't get any necrotic tissue. And you may need to perform imaging, such as CT or MRI, with enhancement if you suspect intraorbital or intracranial spread. The American Joint Committee of Cancer definition for eyelid carcinoma, the 7th edition, is a very useful classification which can help with giving patients information on prognosis. However, there have been no studies currently on prognosis based on this staging for eyelid SCC. It's been used more for systemic SCC. So what are the risk factors for this tumor? Well, we already covered sun exposure. Think about previous skin cancer, previous radiation, and also sirolium therapy, which is important in the history. Differential diagnoses, your basal cell carcinoma is your commonest tumor. So it may be a basal cell, which could be nodular or morphiform and presenting as a possible SCC. Actinic keratosis, chronic inflammatory blepharitis. And again, in some patients, SCCs can masquerade as a blepharitis. So if you have a patient with unilateral blepharitis, which has not resolved or looks to be showing other features such as madarosis, you should be biopsying those sites. Keratoacanthoma is another differential. In fact, some pathologists consider keratoacanthoma to be a low-grade SCC. Papilloma, sebaceous cell carcinoma, nonspecific dermatitis, follicular keratosis, and amelanotic melanoma, as well as pseudoepitheliomatous hypoplasia. Management. So the natural history of this lesion is that spontaneous resolution is not observed with this tumor. So there is no role for observation. The diagnosis requires intervention. And the diagnosis needs to be confirmed, of course, by biopsy. Medical therapy, well, we know that this tumor does express certain growth factor receptors, such as the epidermal growth factor receptor, also known as the HER1 or ERB1. And there are further studies happening to develop immunotherapy targeting such receptors. We also had tyrosine kinase inhibitors like gefetinib and erlotinib have been studies, as well as cetuximab, I beg your pardon. These drugs, however, are not FDA approved for eyelid SCC. Radiation, well, EBRT or external beam radiation is recommended for patients with evidence of perineural invasion, and the doses range from 50 to 90 grays. The target field can be wide, including the forehead, cheek, and cavernous sinus, and also the parotid gland and neck if required. In terms of surgery, of course, you're going to perform your incision biopsy, and then the procedure of choice is total excision with margin-controlled excision, such as frozen section tumor control or Mohs micrographic surgery. And then secondarily, to reestablish function and aesthetics once the tumor has been completely excised. Other considerations, cryotherapy is available as an adjuvant treatment after surgery, or for individuals who refuse surgery or who are poor surgical candidates. And in terms of follow-up, it's very important to see these patients for a number of years. I see mine for at least 3 years every 6 months following excision to ensure that there is no recurrence. How do you prevent these lesions? Well, we mentioned, of course, sun protection and measures such as wearing large frame sunglasses, sun protection creams, and not being exposed to the sun. There can be complications related to the tumor, such as compromise of the eyelid through ptosis or leg ophthalmos or cicatricial changes, or that can occur from the surgery itself. So we can really classify the complications into disease-related and treatment-related complications. In terms of disease-related, well, the tumor can spread perineurally. This can invade the orbit, the forehead, the eyebrow, and intracranially. And there's a study done by McNabb in 1997, which describes that beautifully. Forehead and eyebrow lesions have a high likelihood of perineural invasion because of the close proximity of the nerve bundle. So always test for sensory loss when you see eyelid malignancies. And also do a full orbit examination if you suspect orbital invasion. Do syringing of the nasolacrimal duct if you feel that there's invasion of the drainage system. Palpate for lymph nodes and investigate with imaging if you suspect local or distal invasion or metastasis. Okay, that's the end of that case.